Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a prospective study evaluating the impact of tissue conformation of metastatic disease in breast cancer patients, by Aitan Amir et al. My name is Nancy Davidson, and I am Director of the University of Pittsburgh Cancer Institute and UPMC Cancer Centers in Pittsburgh in the United States. My oncologic specialty is medical oncology. To biopsy or not to biopsy? That is the question. All oncologists are taught early on about the importance of a tissue diagnosis. No meet, no treat is the saying that guides much of what we do at the time of initial diagnosis and staging. Specialists in hematologic oncology frequently carry out serial tissue sampling through repeated blood smears, bone marrow aspirates, and lymph node biopsy to guide further evaluation and management during the course of the illness. But we who practice in solid tumor oncology have been slow to do so. Biopsies are sometimes difficult, and the value in patient management has been hard to assess, so we have often been content to rely on the initial biopsy results. So when do we biopsy in breast cancer and why? Of course, a diagnostic biopsy is done to confirm the diagnosis and assess standard prognostic and predictive markers like grade, histology, estrogen and progesterone receptor expression, and HER2 expression. And we frequently will biopsy to confirm the diagnosis of new metastatic disease because the implications are so grave. But thereafter, not too often. Recently, though, we have wondered if we should change our practice because of the emergence of targeted drugs whose activity is tied to a specific pathway or protein, and the evolution of our understanding that patterns of biomarker expression may change either through natural history or the selective pressure of therapy. We harbor the hope that we might better select therapy and improve outcomes by interrogating the tumor as we decide to introduce a new therapy. To answer this question, Dr. Amir and colleagues asked 151 women with presumed metastatic disease to undergo biopsy over a 2-year period. 137 agreed, and 121 actually underwent biopsy. We do not know how many women were in the denominator. The total number of women with presumed metastatic breast cancer facing a change in therapy who could theoretically have been approached. And we do not know what sites were biopsied, and by what means: image-guided, core biopsy, fine needle aspirates. But a surprisingly high 117 of biopsies, 97%, confirmed the diagnosis of recurrent breast cancer. Biomarker analysis was limited to ER, PR, and HER2. ER and PR determination by immunohistochemistry was possible in 94 or 80% of samples. In these, HER2 FISH was successful in 83 or 88%. Where possible, results from the metastatic biopsy were compared to those of the biopsy from time of diagnosis. The biopsies were safe and acceptable to patients. Only one patient required hospitalization for bleeding from a skin biopsy, and 88% of biopsy patients said they would recommend a metastatic biopsy to other patients with breast cancer. A key finding of this study is that discordance in one or more receptors between original pathology report of the primary lesion and the metastatic biopsy was found in 38% of women. The most common change was loss of PR expression. Here's where the results become a little more problematic. One possible explanation for discordance is false results on the first original biopsy. Ideally, in this study, all original tissues would have been reanalyzed at the time of the study to minimize the impact of potential technical difficulties in assays in the past. And ideally, all original and repeat analyses would give the same results. In fact, only 55% of primary tumors were reanalyzed, and an astounding 13 of 52 showed some discordance between the results on the same tumor when assayed at 2 different times. Differences in expression in ER, PR, and HER2 were all noted. This result surely highlights the recent focus on standardization of assays for ER, PR, and HER2, as recommended by the joint guidelines from the American Society of Clinical Oncology and College of American Pathologists. The remainder of the comparisons suggests that real changes in expression of ER, PR, and/or HER2 have occurred. Of course, the ultimate question is whether biopsy leads to change in therapy and ultimately to improved outcome. In this study, 14% of women had a change in therapy as compared with the pre-biopsy treatment plan. Unfortunately, this relatively large study was not of sufficient size to make any definitive statements about effective biopsy-guided management on outcome. What have we learned? We have learned that we can and should do this, especially at the time of first diagnosis of metastatic disease. Of course, this study has limitations. It was done at a single tertiary care facility with a dedicated team of oncologists and a single pathologist and cytopathologist. This is the best case scenario, and it may not be easy to extend these results to the broad population in general practice. We don't know how many patients were not approached and why, the true denominator for this study. We do know that most who were approached agreed to undergo biopsy and did so safely, reminding us that the single most important block to such biopsy procedures is the willingness of the doctor to recommend the procedure. We learned again about the need for standard, high-quality biomarker testing across clinical practice. We learned that 14% of patients had a change in therapy, surely a high enough result to warrant biopsy. And this number will only get higher as we introduce other targeted agents into practice and try to decipher how best to deploy them. And we have also learned that serial biopsy must become a part of the fabric for clinical trials of new targeted therapies. We must insist on serial biopsies for correlative sciences and target validation as part of these studies. It is no longer acceptable to view these endpoints as optional. Can other tests supplant biopsy? Perhaps with time. The hope that assays of circulating tumor cells might provide the same biological insights is as yet an unfulfilled promise but worthy of study. And the hope that the fruits of the omics era will contribute is great. Finally, we know that we in breast cancer are not alone. The recently published results of the BATTLE trial, a study of targeted therapy in non-small cell lung cancer using a molecularly informed adaptive design strategy, suggests that biopsy and molecular characterization will likely become standard practice for many individuals with metastatic disease. As with any testing strategy, though, it will be incumbent on us to show that the test results will guide patient and doctor decision-making and improve outcome. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.